Introduce our first speaker, Dr. Raghav Sundar, who is one of our newest faculty members. He's leading the gastroesophageal cancer program, and he will speak on that topic.
Thank you very much for giving me the opportunity to present some of the upper GI updates that we have seen at ASCO this year. These are my disclosures. I'm going to start on a somber note. If you look at the incidence of cancers on the column on the left over here, you can see that there are only a couple of GI cancers up here with colorectal, stomach, and liver. But if you look at the mortality of these cancers, you can see a lot of GI cancers upgrading themselves into the top 10. We have esophageal, pancreatic, stomach, liver, and colorectal. So we aren't really doing great in the GI cancer space, but hopefully in the next hour, we'll show you a little bit of the kinds of things we are doing here to improve the survival for these patients with pretty morbid disease. So focusing mostly on gastroesophageal cancers here, for resectable early stage gastroesophageal cancers, the traditional standards of care was multimodal treatment with radiation, surgery, and chemotherapy. And there's been a lot of debate around how we integrate all these different components into treatment for these patients. But increasingly, we are moving toward a perioperative approach, particularly for the gastroesophageal junction adenocarcinomas and the gastric adenocarcinomas, where most patients are going to get chemotherapy, followed by surgery, and more chemotherapy. And at ASCO this year, we saw practice-changing plenary, which we'll talk a little bit about. As a little bit of a background, FLOT was the standard of care where patients receive 4 cycles of FLOT, followed by surgery, and then another 4 cycles of FLOT. For resectable adenocarcinomas, and this was kind of accepted as the standard of care across multiple different guidelines, despite differences in the way these patients were managed across the Western populations and in Asia. And so this was a plenary that we saw at ASCO, which is the Matterhorn study, that looked at improving upon the FLOT regimen. And so patients were randomized to either having FLOT or have FLOT in combination with durvalumab. There are a couple of things to point out here. There was a lot of confusion around the nomenclature of the DFLOT regimen, where it says 2 cycles of 2 cycles pre-op and then 2 cycles post-op, and many folks were thinking that this means patients were getting lesser than the 4 cycles of FLOT that we are more comfortable with. But actually, the 2 cycles were mostly to do with the durvalumab, which went in every 4 weeks. But the patients did receive the FLOT on day 1 and day 15 of 4 weekly cycles. So they did get 4 cycles of FLOT with 2 cycles of durva pre and post-op. And then, without a lot of rationale, there was another 10 cycles of adjuvant durvalumab that was added as maintenance treatment or adjuvant treatment after the surgery. And so the good thing about the results from this study is that the rates of treatment and surgery completion were similar between both arms, which meant that the addition of the durvalumab didn't affect surgical outcomes. There was a very good R0 resection rate of 92% on both arms. And if you look at the baseline characteristics, this is actually mostly a Western population study with only about 20% of the patients included from Asia. A majority of the patients were node-positive disease, suggesting high burden of disease in these patients. And about a third of the patients, 32%, were gastroesophageal junction adenocarcinomas. And this was the primary endpoint of the study, which was met. The addition of durvalumab improved event-free survival compared to FLOT alone, with a hazards ratio of 0.71 and a good p-value. The curve separated early and stayed separated throughout, and there's an improvement at the two-year EFS by about 8%. There's no median survival for the DFLOT regimen at this point of time. We are going to see an update at ESMO next month. In terms of subgroup analyses, you can see that actually the addition of durvalumab to FLOT was consistent across multiple subgroups. Importantly, our elderly patients also derived a benefit from the addition of durvalumab. There wasn't much difference in the response rates between the Asians and the non-Asian population. Again, something that we see a fair number of differences in other trials. The gastroesophageal junction carcinomas actually had similar or better benefit from the addition of the durvalumab. And there is some controversy on the PD-L1 expression, where the study did not stratify or randomize based on PD-L1 expression, but you can see that the benefit in the TAP score, which is similar to the CPS score, there was actually less benefit here. And this actually led to an update in the NCCN guidelines, where the addition of the durvalumab has been restricted to only patients with a CPS score or a TAP score of 1 or greater. The overall survival had an interim readout that shows that it's trending towards a positive result, but it's not statistically significant at this point of time. We hope we'll see some updates at ESMO next month. And there was a previous readout of the pathological complete response rates that showed an improvement of about 12% with the addition of durvalumab, which again in our patient population is going to be pretty important. And in terms of treatment delivery, again, it was similar in both arms, and the durvalumab addition didn't affect the administration of the float, suggesting that the adverse events that were seen in this was only slightly higher for the durvalumab arm, with no new major concerns that were seen for the addition of durvalumab. I'm not going to iterate the adverse events, but there was no major differences. Most of the toxicities were seen from the float itself. And so this is going to be practice changing. We have already started to adopt the addition of durvalumab to float for our patients for resectable, locally advanced adenocarcinomas of the gastroesophageal junction and the stomach. We also had an update from Checkmate 577. This was a study that had patients randomized to receive a year of nivolumab after having chemoradiation, with most of the patients having the cross regimen followed by surgery. And for those patients that did not achieve a pathological complete response, they could get a year of nivolumab. And this is something that we've been practicing ever since the primary study, the EFS read out for 3 or 4 years ago. And this year at ASCO, we actually saw this was the disease-free survival that we were familiar with an improvement or doubling of the disease-free survival to 21.8 months from 10.8 months. But this year, we actually saw the overall survival results finally, and actually, disappointingly, the overall survival didn't achieve a statistically significant result, although numerically there was a 16-month improvement for the addition of nivolumab. If you break it down into the subgroup analyses, you can see that a majority of the patients that benefited from the nivolumab was essentially the ones that had a PD-L1 expression with a CPS score of 1 or greater. And so this is something that I think will come to a debate on whether which approach is going to be preferable, whether the Checkmate 577 approach with the addition of nivolumab with chemorads, or going through the deflot regimen, and we could have a little bit of a discussion about this, although majority of the group is moving towards the Matterhorn. And this essentially brings the Kaplan-Meier curves of the CPS scores. You can see that the ones with a score of 1 or greater had a benefit with the addition of nivolumab, but there was actually a flipping of the curves for the CPS score of less than 1. All right, moving on to the metastatic setting now. This is actually a very exciting space. We have multiple new therapeutic targets that we are exploring in upper GI cancers. Today we'll talk a little bit about the improvements in HER2, as well as updates in HER2, as well as a new therapeutic target, Claudin 18.2. So this is the current standard of care for the management of advanced gastroesophageal cancers. We have HER2, PD-L1, Claudin 18.2, and mismatch repair deficiency as the different biomarkers we use to select patients for various targeted therapies that we add to a chemotherapy backbone. And in the HER2 space, we're going to talk a little bit about the DESTINY-Gastric04, which is looking at trastuzumab deruxtecan, which is an antibody-drug conjugate with a exatecan payload to linked to trastuzumab with a cleavable linker. And with TDXD, this was previously already approved in the United States for second line or later based on the Destiny Gastric 01 study. Although in that study, the TDXD was actually tested in third line or later compared to chemotherapy. But in the rest of the world, because the approvals was for TDXD was in third line, they actually reran the trial comparing it against paclitaxel and ramucirumab in second line. And this is practice reaffirming in the United States because, again, the TDXD had a clinically meaningful and statistically significant improvement in overall survival of 14.7 months, which is pretty impressive for second-line treatments compared to PACRAM with 11.4 months. Switching gears to Claudin 18.2, which is a tight junction protein that is normally expressed in the gastric mucosa, and in cancer, it loses the polarity and overexpresses on the cell surface. And we have zolbetuximab, which is the first monoclonal antibody and a first-in-human, first-in-class approval for gastroesophageal cancers for Claudin 18.2 tumors based on the Spotlight and GLOW trials. We do have multiple different therapeutic targets, therapeutic approaches that we are exploring to target Claudin 18.2, including the CAR Ts that we saw data at ASCO this year with Satricel essentially. So this is the first randomized CAR T trial in solid tumors comparing Satricel, which is the Claudin 18.2 CAR T, versus a physician's choice of chemotherapy. All patients had an apheresis after randomization and had at least 2 prior lines of treatment, which could have included Claudin 18.2 inhibitors, and then were randomized to receive either Satricel or chemotherapy. And again, this had an overall survival benefit of about 3 months for Satricel compared to chemotherapy. One would argue that for CAR Ts, this is a little bit disappointing, and we would hope for longer survivals with more flattening of the curve. But again, considering how heterogeneous gastroesophageal cancers are, this is a clinically significant sort of step in the right direction towards solid tumor CAR Ts. And we'll hear a little bit more about this from Mike Hurwitz later on today. It was definitely a little bit more toxic. The CAR T approach was more toxic compared to the chemotherapy. Of course, we spoke about this. There are different ways that we are targeting Claudin. There are the antibody drug conjugates, the bispecifics, the monoclonal antibodies, as well as CAR T. So this is a hot space with multiple trials that we are opening at Yale. Biomarker co-expression of these cancers is quite important as well, where one tumor could express multiple biomarkers such as Claudin and PD-L1. And we are opening the Lucerna trial at Yale, which looks at combining both pembrolizumab as well as zolbetuximab for dual expressing tumors. And lastly, to end with FGFR2b, which is an emerging biomarker, we saw promising phase 2 studies with survival benefits from the FIGHT trial, looking at bemarituzumab in combination with chemotherapy. And we are going to see a readout of Fortitude 101, which had a press release saying that may be a positive study for the addition of bemarituzumab to FOLFOX in frontline treatment, and that's going to read out at ESMO this year as well. And so I'm going to end with a few take-homes. Matterhorn is definitely practice-changing. The question will be who to not give durvalumab, considering it's fairly well added to FLOT. If patients are fit for FLOT, they should be fit for DFLOT. We are awaiting the overall survival data. Checkmate 577 is negative for the OS in the all-comer population. However, if patients have already had chemorads and surgery and didn't achieve pathological complete response, it is still reasonable to continue to offer them nivolumab. DG04 is practice reaffirming in the United States, and it is very hard to beat paclitaxel and ramucirumab. So the questions will remain around who we need to rebiopsy to prove the HER2 status to give the TDXD. But this is exciting times for precision oncology in gastroesophageal cancers. And I'll end with that. Thank you.
I think we're going to wait to take questions until the end of the GI session. So Dr. Sundar, thank you so much. It's been wonderful to have you here over the last year, and please stay tuned for trials. As Dr. Sundar mentioned, this is a really exciting, actively changing space in upper GI cancers. So our next speaker is Dr. Michael Cecchini, who is a co-leader of our colorectal cancer program. He's also our new leader for our clinical research team, and he will be addressing colorectal cancers.
All right. Well, we're at a tennis club, so I figured Raghav and I are kind of playing doubles here, trying to cover the whole court for GI cancers. Here are my disclosures. So I have an ambitious plan until Roy yanks me down to get through 5 abstracts. So I'm going to talk about 3 for localized disease and 2 for metastatic disease that I think are pretty much all practice changing. So let's jump right in with atomic. So this was one of the plenary sessions. So we had 2 GI plenary sessions, plenary abstract or presentations this year. One that Dr. Sundar just went through, and then atomic, which was for mismatch repair deficient colorectal cancer, evaluating adjuvant FOLFOX plus immunotherapy versus FOLFOX alone. It's a cooperative group study, so it's always great to see this contribution from our cooperative groups. So mismatch repair deficient colorectal cancer, we know it as a highly sensitive subtype of the disease for immunotherapy. We think about it as a rare subtype for metastatic disease, maybe 4%, but its incidence for localized disease is about 15–20%. And this was evaluating patients with stage 3 disease, where again, the standard of care up until this abstract has arguably been adjuvant chemotherapy with FOLFOX. Again, we already know that they're highly sensitive to immune therapy, so there's always been this urge to look at immune checkpoint inhibitors for these patients. This is a study design of the atomic study. So you can see patients with stage 3 colorectal cancer, that means node-positive disease, were randomized 1:1 to FOLFOX plus atezo for 6 months, and then another 6 months of atezolizumab versus FOLFOX alone for 6 months. Now, this cooperative group study, it took a long time. Arguably, 6 months of adjuvant chemotherapy isn't how much chemotherapy would give a lot of these patients at this point. So that's, I think, a deficiency. We would oftentimes end up doing 3 months for lower risk disease. They saw a hazard ratio of 0.6 as their target HR. This is a disease-free survival curve. So 3-year DFS is a very validated endpoint in colorectal cancer, and you can see at that landmark time point, 86 for 76%, roughly 10% absolute improvement in DFS, highly statistically significant with a hazard ratio of 0.5. So this is certainly a positive study, and we'll see as overall survival eventually matures. But again, DFS was the endpoint. Toxicity-wise, there was nothing really particularly unexpected. We see a little bit higher rates of grade 4 neutropenia for unclear reasons in the investigational arm. And of course, you see some immune-related adverse events, but nothing that's overly concerning that we wouldn't expect. But really, how does this fit with the drugs the approaches we have for this disease right now? This is from the plenary for melanoma a couple of years, where they were evaluating neoadjuvant immunotherapy versus adjuvant immunotherapy. And again, Atomic's evaluating adjuvant chemo versus adjuvant immunotherapy. But is that really the right question, given some data that came out throughout the course of the Atomic study? So this is all predicated on the idea that giving some immune checkpoint inhibitor maybe is more effective when there's some intact tumor, more likely to ultimately develop immune responses. So these are figures from Dr. Shalabi, who did the discussant for the Atomic study, used with her permission, looking at neoadjuvant IPI plus Nivo for 2 cycles. And you can't probably even tell that this is a waterfall plot because it looks so unusual. Everybody there you can see with almost a major or complete pathologic response, about 68% with a complete pathologic response with 2 doses of immune checkpoint inhibitor given in the neoadjuvant setting, single-arm study for mismatch repair deficient colorectal cancer for stage 2 and stage 3. Always hard to stage these radiographically. And then even more impressive, it doesn't look like a survival curve either because it's just flat, 100% disease-free survival. So this has been kind of recapitulated in a few different studies. We've all heard about the rectal study. And so the path CR rates are somewhere between 50 to 80%, depending on if it's dual immune checkpoint or single immune checkpoint inhibitor. So I would argue that for patients that get resected, adjuvant FOLFOX plus atezolizumab is a reasonable option, although again, the the duration of the chemo, I think, will not be 6 months for most patients. So I don't think the true regimen of ATOMIC will be used very much. But for patients that get upfront surgical resection, chemoimmunotherapy is a reasonable option. But I think we really need to be thinking about how patients make it into our clinics with mismatch repair deficient colorectal cancer and whether or not those patients should be getting neoadjuvant immune checkpoint inhibitors. And I would argue that should really be an approach we start doing more. Is the chemotherapy even necessary in the first place? I'm talking about maybe going from 6 to 3 months. I think a big question is if you can get away with 2 doses of ipi/nivo in the neoadjuvant setting, do we even need that adjuvant FOLFOX in the adjuvant setting? I don't think that study is ever going to be done now. I think our field is going to move forward with new ways to develop to deliver neoadjuvant immune therapy in this disease. So what about exercise? So the next study is the challenge trial. So this was from the Canadian cooperative group looking at implementing exercise in the adjuvant setting. And there's a lot of preclinical evidence that a lot of it in clinical as well. It came out of Boston showing that exercise had direct impacts on colorectal cancer cell lines in in vivo models and observational data that was certainly associated with better outcomes. So this study sought to recommend exercise to everybody, as we do in our colorectal cancer clinics, but it really had a structured exercise program intervention versus giving pamphlets and recommendations, essentially. But first, what's a MET? Because this is what the study used to kind of measure improvements in activity. So a MET is what you all that are sitting down are expanding in the next hour listening to the GI cancers and not getting up to move. Whereas if you walk, you increase your METs 4 MET hours. So the study tried to increase the METs by about 10 METs per hour per week. And this was enrolling patients that had less than 150 minutes at baseline of moderate to strenuous exercise. So again, randomized 1-to-1, high-risk stage 2, stage 3 colorectal cancer to a structured exercise program. That's physical therapists, personal trainers, plus health education materials versus just giving the health education materials and trying to see was disease-free survival improved. This was the behavior support that they implemented. Again, it's broken up into phases. So first 6 months, then the second 6 months, and then years 2 and 3, requiring varying degrees of recommended and mandatory physical recommendations and actual physical activity. As you can see, for the first 6 months, it was mandatory. So they enrolled almost 900 patients. This is, again, done after adjuvant chemotherapy for the majority of patients. You can see in the lower left here, adherence drops down, but it's pretty good throughout the duration of the study, from 83 to 68 to 63% for those first 6 months, second 6 months, and years 2 and 3. This is a disease-free survival. So you can see here, it's kind of small, but you can see here a hazard ratio of 0.71 for DFS with structured exercise program over just giving out the exercise recommendations. So this is as impressive as giving somebody a new adjuvant therapy, right? This is impressive as a potential drug. When we look here on the right, you can see the majority of these impacts on disease-free survival were by a reduction in metastatic recurrence, principally the liver, as well as the reductions in breast and prostate cancer. Not only disease-free survival, but there's an OS benefit, and this was calculated to be done due to reductions in colorectal cancer death, not just things like cardiovascular mortality, et cetera. So this was a very exciting study to see the results from. And like I said earlier, if we put these findings into context in that table there of all the other drugs we use in various cancers, it's right up there with developing a new treatment. So I think we can call this exercise mab, and then we'll get the standing ovations for it. But we don't know what's the mechanistic basis of this. We think that this has something to do with immune surveillance. And I think one of the biggest things in the US is how are we going to operationalize this? How are we going to make it so that everybody has access to these structured exercise programs? So you can certainly envision some issues here where patients with more resources are going to be able to go out and seek personal trainers, and patients without them will not. So just in 2 slides, I'll talk about the Alaska data because it has so much relation to these things. And this was actually first presented at GI ASCO earlier this year, and now it's published in New England Journal. This evaluated adjuvant aspirin, low-dose aspirin, 160 milligrams, as part of the adjuvant therapy for stage 2 and stage 3 colorectal cancer. Based on other preliminary data and other clinical data, frankly, this was restricted to patients with PIK3CA, PIK3R1, and PTEN mutations in 2 arms, that were randomized to aspirin 160 or placebo. And arm A is the left and arm B is the right here. And these also delivered highly statistically significant disease-free and overall survival benefits with adjuvant aspirin for stage 2 and stage 3. So within the last year, we've seen adjuvant exercise, adjuvant aspirin as clear interventions that can help our patients with resected colorectal cancer. Predicated on this has made it into the NCCN guidelines, and this has changed how we practice because now we need to sequence these tumors too because we don't know who has a PIK3CA mutation and who doesn't. We also have 81 milligrams, so we have to figure out how to get that up to 160. I just give my patients 2 baby aspirins. So it's Friday, so what are we going to do for Monday morning clinic? For stage 3 disease, I think that if I see a patient that has not yet gone to surgery, I think it's reasonable if they have stage 3 or 2 or 3, stage 3 disease, I would consider a neoadjuvant immune checkpoint inhibitor. I think stage 2 disease, we're still figuring out how to stage those patients clinically, and maybe even stage 3. But for patients that get resected, it's reasonable to consider the atomic regimen of FOLFOX plus atezolizumab. For high-risk stage 2 and 3, I think all of our patients, we should be recommending exercise, as we already have been doing. We don't yet have a way to operationalize the structured exercise program, but really discussing in depth with our patients the importance of this intervention will be helpful. And again, adjuvant aspirin is something I'm recommending for my patients with PIK3CA or honestly PIK3R1 and PTEN mutations. The NCCN guidelines is only right now for PIK3CA exons 9 and 20. I think the others will follow eventually. So last couple of abstracts are for metastatic disease. We saw, they're basically both encore presentations, frankly, but we saw updates to the breakwater data, which is FOLFOX plus encorafenib and cetuximab for BRAF V600E mutated colorectal cancer. So this is a RAF inhibitor with EGFR inhibitor plus its chemotherapy versus standard of care. So this is the breakwater design. So this was originally presented by Dr. Scott Kopetz in January, and then this is Dr. Alez presented at ASCO. And it's a randomized 1-to-1-to-1 for metastatic BRAF V600E mutated colorectal cancer. And you can see here, there's 3 arms. Encorafenib, cetuximab alone. You can see there's fewer patients because it closed early. Encorafenib, cetuximab plus FOLFOX, or standard of care. You can see dual primary endpoints of PFS and overall response rate. It's a study with 637 patients with overall response rate as one of the primary endpoints. And that's because it's actually the first example of Project Frontrunner with the FDA, which is estimated to have sped up the approval of this regimen by probably about 12 months. And that basically by hitting a certain response rate, it allowed an early look at the OS data for confirmation. And so ORR and OS read out before PFS. This is the ORR. We see 61% essentially in the investigational arm with FOLFOX versus 40% with standard of care chemotherapy. I want to remind everybody this is the most aggressive molecular subtype of the disease, where if you always look at a survival curve, they're always doing, unfortunately, the worst. Pretty comparable toxicity rates between the arms, and nothing really standing out to me personally in this tornado plot. This is a survival curve. And you can see in the upper right is the investigational arm plus FOLFOX, and so that's encorafenib cetuximab. If you can see up there in the fine print, the median survival there is 30 months, which is absolutely stunning for this aggressive molecular subtype of the disease. You can see the median survival with the standard of care being 15 months, and then the encorafenib cetuximab arm there in the middle, 19.5 months, a little bit underpowered there. And then we saw this updated PFS data, but we already had OS and overall response rate. Again, reiterating that median PFS with the encorafenib cetuximab is now over a year, whereas the first Whereas, so BRAF V600E mutated colorectal cancer essentially now has overall survival rates similar to non-BRAF V600E disease. So in conclusion, this is the standard of care for patients that can tolerate multi-agent chemotherapy, given all significant efficacy, efficacy endpoints showing significant improvements. But also for patients that are not candidates for multi-agent chemotherapy, you can see that encorafenib cetuximab arm doing quite well, and I do think that that is something to consider for those patients. We'll end in just a couple of slides talking about the Checkmate 8HW study. This was a 3-arm study as well, and so we've seen some updates in the nivo plus ipi versus nivo arm for mismatch repaired deficient metastatic colorectal cancer. And so here we're comparing these 2 arms, certainly more relevant than comparing the chemotherapy arm, as that is no longer the standard of care. We see with dual immune checkpoint inhibitor, or ipi-nivo versus nivo, you see the response rates up to 71 versus 58%. And you can see at the landmark time points of 24 and 36 months, these quite impressive separation of these curves here with 71 and 55% and hazard ratio of 0.62. So what do I do in my Monday morning clinic for these 2 scenarios with BRAF V600E? For patients that can tolerate multi-agent chemotherapy, it's going to be FOLFOX plus encorafenib and cetuximab. For patients that can't tolerate multi-agent chemotherapy, I would use encorafenib and cetuximab by itself. And for mismatch repair deficient disease, I use a dual immune checkpoint inhibitor for everybody that is a candidate for that. I think for patients that are not, where you're concerned about certain toxicities, pembrolizumab alone would be reasonable. And here are some pictures from around New Haven of me getting some Mets with my kids. So that's East Rock in the middle.
Thank you, Dr. Cecchini. So we are going to round out the GI session with a case discussion being led by Dr. Jeremy Kortmansky.
All right, I guess they're all in the dark. All right, so we are between you and snacks. So I am Jeremy Kortmansky. I am a GI medical oncologist, and I am joined by a quadrumvirate of specialists in GI cancers, Kimberly Johung, radiation oncology, John Kunstman, surgical oncology, Haddon Pantel, colorectal surgery, and then Thejal Srikumar, also a GI medical oncologist. And I think just this gathering is, for me, what I enjoy the most about GI oncology is that it can't be done individually. It really does take a multidisciplinary team to take care of our patients. And so to take advantage of the expertise that is here, I'm going to present a case on rectal cancer to keep the conversation spontaneous. I did not tell anybody what's about to happen. So this is a 37-year-old male who presented with several years of rectal discomfort, 4 months of increasing rectal pain, incomplete evacuation, and blood mixed with stool, and ultimately developed weight loss, which is what prompted a gastroenterology consultation. Patient has a past medical history of obesity, a social history of occasional alcohol use. He's a non-smoker. He's a truck driver. He has a family history of a grandfather with prostate cancer and a grandmother with breast cancer. And so he finally had a colonoscopy, which was actually completed 2 months after he had that initial GI consultation, showing a infiltrative, friable, and ulcerated non-obstructing mass found in the distal rectum. The mass measured 10 centimeters in length, extending from but not directly involving the anal verge. And the biopsy showed invasive, moderately differentiated adenocarcinoma with preserved expression of the mismatch repair enzyme, so mismatch repair proficient, and HER2 1+. So I'll just pause right there and ask Thejal, how does this happen?
Okay, so we had that wonderful presentation by Dr. Geary and Dr. Borstelman this morning about early onset cancer, and this is all over the news. We're very worried about this. We don't understand why it's happening. There are a lot of theories, as I think Dr. Geary had touched on, specifically for colorectal cancer. Certainly we're concerned about the rise in obesity, that correlates with this increase in early onset of disease. Also concerns about sedentary lifestyle. Could these things be influencing this? Could there be a mechanism through adipokines, for example, that are leading to a pro-inflammatory state? As Dr. Geary mentioned, there's also a lot of concerns about environmental exposures. I have patients coming into clinic asking me about microplastics. I think we don't know yet. What we do know is that the microbiome of young adults who have colorectal cancer is different than those with older adults, and also with healthy comparisons. And so is there something in the environment that's changing our gut microbiome, which is therefore causing dysbiosis and changing our gut barrier? It's certainly possible. As Dr. Geary mentioned, 20% of these patients do have an inherited mutation that are oftentimes identified. So genetic testing is incredibly important. And thankfully, our genetics colleagues here have now just very recently set up a pathway for us to send point of care testing, actually, from clinic, to be able to get that sent off right away and save some of the wait times for us to understand, is there an inherited predisposition, which might change the way that we think about how the cancer developed and how to treat it.
All right, thank you. So moving along, so anytime somebody has a colonoscopy with a new cancer, the next step is staging. And so this patient had a CT scan. The CT of the chest was negative. The abdomen shows a low density hepatic lesions, the largest in segment 6, measuring 6.6 centimeters, and an additional lesion in segment 7, measuring 3.9 centimeters. Within the pelvis was a circumferential thickening of the distal rectum, just proximal to the anus, with multiple prominent mesorectal lymph nodes measuring up to 0.8 centimeters. The patient had an MRI of the pelvis, which was a non-rectal protocol, presumably because the patient already had metastatic disease. But I'll ask Haddon, what is an MRI? What does a rectal protocol give us that a regular MRI doesn't?
Thank you, and that's correct. These are all surprise questions. I think there's a couple things. The first is the addition of, we use ultrasound gel within the lumen, and that can distend it and really give us a better sense as far as distance between the tumor and the pelvic floor, which is essential. But also can help with T-staging. I think traditionally people think of endorectal ultrasound as the strength, of T-staging, and MRI is more helpful for circumferential margin and lymph nodes. But I think the addition of the gel is beneficial for that. And then the other thing that's important is what I guess we refer to as bread loafing, but you want to make sure that your axial cuts are in line with the tumor and the rectum, as opposed to in line with the patient, because that's very helpful as far as determining height of the tumor from the pelvic floor. So you want to be, orienting or bread loafing it in parallel or in the same plane as the rectum of the tumor, as opposed to the patient themselves. And I think also, the one thing is the synoptic reporting as well. So it's not just the technique of performing the MRI, but also how it's read, and including important things like threatened circumferential radial margin. In this case, we've got lateral pelvic lymph node. Is this a suspicious lymph node or not? Because ultimately what we want to do is get this patient an accurate clinical stage.
All right, so in addition to the four specialists up here, I think a really strong radiologist reading these images is going to be important. So some final information, the CEA was 40. The patient was a normal metabolizer of DPD. and by tumor profiling, in addition to some other mutations, had a KRAS mutation. And so by all measures, to me at least, John, the disease in the liver looks resectable. And so how do we now think about this patient that has a large rectal tumor but resectable liver disease?
Yeah, I agree completely. The lesions are resectable. That being said, in synchronous disease like this, you always wonder whether that's the tip of the iceberg or the whole story with regards to the burden of metastatic disease. I think certainly in a 37-year-old, you're going to want to be treating this patient aggressively. It's important to really convey to him that there is a pathway to a cure here. It's not necessarily that we're going to get there. Obviously, time will tell. But this patient has an imminently resectable oligometastatic burden. Certainly, there has to be a plan to address all of the disease. I think this is really a critical point where a group like this, or including the radiologist and pathologist, really need to come together to come up with a plan and a sequencing of treatments. But even though it's upfront resectable, I think this patient really needs to pass a biologic test of time. The last thing we'd want to do, if we were going to operate on him right now, most of the right liver would have to come out. If he then developed a lesion in the left liver 3 months, 6 months down the line, or even 6 years down the line, that might substantially limit our options.
So with that in mind, Thejal, what are your thoughts on initial therapy for this patient?
Yeah, thanks. And I did want to just note here about the DPD, which I feel like is something that, particularly in the last year, we have really made a push to send on all of our patients. So DPD, dihydropyrimidine, dehydrogenase. We check for mutations in this to see whether or not there is a chance that there could be issues with metabolism of the 5-fluorouracil. And we know that if these mutations exist, then the 5-FU can be fatal. So as a practice now, we are sending, or at least discussing with our patients regarding sending DPD prior to initiating 5-FU-based chemotherapy for all of them. So much so that when you're ordering the treatment plans, you have to acknowledge whether or not you have ordered this, and if not, why. So I think this is, I think from a public health and policy standpoint, something that is actively being worked on to try to get this covered for all of our patients as well. But from the standpoint of systemic therapy, there is a balance between how aggressively you need to cytoreduce the tumors to get to resectability if there's any concern about initial borderline or concern that it may not be upfront resectable, versus the toxicities that you may accumulate from more aggressive upfront regimens. So typically, this of course is in discussion with all of our colleagues, but if someone is if we evaluate the imaging and from our surgical oncology colleagues think that it's upfront resectable, we will typically proceed with a doublet regimen, like full Fox as opposed to full Fury, with the concern of potential additional liver toxicity added by irinotecan. And we would do just the doublet without a biologic. However, if there is concern initially about the level of resectability, those are the situations that you would consider doing a more aggressive regimen, whether this would mean a triplet regimen, full FOLFIRINOX, or whether or not you would consider adding a biologic in this standpoint. This patient has a KRAS mutation, but in somebody who has KRAS wild-type left-sided disease or rectal cancer, you could consider adding an EGFR inhibitor in those situations as well. We typically avoid bevacizumab, if our goal is to try to get to surgery, to avoid the delays that are related and potential complications from surgery in that situation.
Okay, so if we're going to start with chemotherapy, but the overall approach is a curative approach. And so that requires not just addressing the disease in the liver, but also optimizing control of the disease in the rectum as well. And so as we embark on chemotherapy, Kim, where do we still need to do radiation? Where do we place it? What does it look like?
So I prepped my mic because I could tell I was up next.
Yeah.
So the bottom line is if we are pursuing curative intent therapy, we certainly want to incorporate pelvic radiation into that treatment plan for the local control benefit. I would say there is one caveat, which would be if we extrapolate from the Prospect trial, which looked at patients with kind of that intermediate risk locally advanced rectal cancer, so T2N1 disease or T3N0 to N1, who have had response to their initial FOLFOX chemotherapy and omit pelvic chemoradiation, their survival outcomes were the same. And in the patient-reported quality of life outcomes, certainly some benefits to avoiding pelvic chemoradiation if that's feasible. So I think that's something we would keep in mind, particularly for a young patient. But other than that scenario, this would be a group of patients that we would incorporate radiation.
And where do you think about placing that radiation? I mean, there's this thought that radiation works better the more in advance of surgery there is. So is it something we should be doing up front? Is it something that we do after some chemotherapy? Where would you think is ideal?
I think with the presentation of synchronous metastatic disease, we're going to start with upfront systemic therapy. The question of sequencing of local therapy versus the FOLFOX FOLFIRINOX chemotherapy does come into question when you're thinking about something like organ preservation. So I think in a scenario where we are considering avoidance of a TME, particularly in a younger patient or a patient with a distal rectal tumor that would require an APR, we do have data to say that the likelihood of TME-free survival is higher if you lead with pelvic radiation. But in this case where there is metastatic disease, I think we would prioritize the chemotherapy. And then timing of pelvic radiation, really, I would lean on my surgeons in terms of, particularly for the liver disease, when it is appropriate to try to resect, which is a balance of some chemotherapy on board, but not too much that you have such a response that it becomes difficult to try to get a complete resection. So I'll pass it to John.
I was going to have you pass it to Haddon.
Both.
Yeah, I think Kim's point is great, and also talking about Prospect, because there's rectal cancer and there's rectal cancer. So this is a man with a bulky distal tumor with a lateral pelvic lymph node. So this is a patient who is going to be a technically challenging operation with bulky disease. So this is, this is not someone where they're going to be a high risk for local recurrence. So yeah, I completely agree with that. And to the point about assessing for treatment response and then timing of radiation, right? We know that as you wait more, you're going to have a better response. So I think it's really hard to tell with the current data because they don't control for time between radiation and assessment of response. I can't think of a biologic reason besides really just time. But usually we plan on operating roughly 8 to 10 weeks after completion of long course because we know that provides us additional time. So that's usually what we think about for timing.
And is there any consideration for non-operative management in this patient?
Yeah, I think so. The thing that it really has to start with a discussion when you first meet the patient. It's always nice to have a good exam and sort of a baseline and saying, here's where we're starting, this is where we're at, these are your goals, expectations, this is what you're looking for. Because I think it's a case-by-case basis too. And then also just assessing, because if you are going to go down a non-operative approach, you've got to know what you're feeling, what the tumor feels like, the location, the endoscopic view right from the start, because it's going to really be important as far as painting that picture in your own mind, the next flex sig, the next exam, and moving forward over the next really 5 years.
So there is a component of this of really patient compliance because the follow-up for non-operative management is pretty intense.
Yeah, I think compliance and also there is a risk of I don't call it local recurrence, local regrowth, right? Because if they have a response and then it comes back, it's not really a recurrence. It's just that we can now see it again. So also the psychology of that. Some people want a shot of saying, I want to make sure that I'm doing everything, and some people want to avoid it. And I think also like this guy's a truck driver, so a low pelvic anastomosis may be something that's challenging for him. Maybe he is facing an APR, so that may also play into a shared decision with the patient.
Okay, so this patient went on to receive Folfox, or actually Zelox, so for 4 cycles. And after 4 cycles of Zelox, had a follow-up scan showing marked improvement in the 2 hypodense masses, now measuring 2.7 and 3.2 centimeters. So, practically a 50% reduction in their size following 3 months of chemotherapy. The primary rectal tumor, I guess I had updated those for there, I guess it didn't make it, but that also showed a reduction in size of the primary tumor, not as substantially, but probably by about 35%. So was resectable up front, seems more resectable now. So what should we do next? John?
By naming me, I think you made your biases clear. Just resectable now. I think the important thing is that there's a lot of rationale for doing a liver-first approach to addressing the surgical aspects of this case. I think also just to add to Kim and Haddon's point, if the patient has their hepatic disease addressed, there's this recovery period where it's actually quite convenient to slot in the radiation therapy while they're recovering from their hepatectomy, and that 8 to 10 weeks is elapsing and that clock is always ticking. It's a very nice sequencing of treatment. It doesn't always work out that way, of course. I think the important considerations for this case, there's no additional lesions. You've had some cytoreduction. I would just note that you have 1 lesion that's now under 3 centimeters. We have collision data from this past year. That trial was just published, that thermal ablation, microwave frequency ablation for lesions under 3 centimeters is an acceptable approach in conjunction with resection. That being said, this is a peripheral enough lesion. This would be a relatively straightforward laparoscopic resection. With a very large future liver remnant. So this is an operation I think the patient would recover from quite nicely. That being said, the other consideration to that is whether we do a sequenced or a synchronous approach in the operating room. I think for a low rectal tumor, even a mid-rectal tumor, an LAR, a potential ostomy, those are the kind of operations we like to sequence. That being said, if this was, say, a right hepatectomy, or sorry, a right hemicolectomy plus this kind of thing, that can be done at the same operation in good surgical candidates. So, an excellent candidate for local control. He's also young enough, you could consider, maybe not with the primary in place, but an adjuvant hepatic artery infusion pump. Statistically speaking, this patient's most likely site of recurrence is in the liver. And our program certainly has experience doing that. So, anyways.
So, Kim, how easy is it to get radiation in that postoperative time point?
I think you're asking me about short course versus long course radiation here. So the most recent data we have is the long-term follow-up from the Rapido study. Really, that was a study looking at TNT, but what we learned from that is on the TNT arm, which incorporated short course radiation, at 5 years, there was a higher local recurrence rate than expected of 10%. This patient certainly has risk factors for local recurrence, being the distal location, that lateral pelvic sidewall node. Other risk factors would be T4 disease, EMVI. So I think I would like for this patient to try to work in chemoradiation long course if feasible, and then would defer to Thejal on this, but always the option to add additional cycles of the chemotherapy in that delay time to surgical resection. That being said, I think short course radiation, this is one of the scenarios where there are multiple drivers of prognosis, and we're trying to work in multiple treatments into the treatment paradigm. So short course is certainly something to consider when we're dealing with a patient with a synchronous metastasis.
So I think the one of the messages here is that surgically managing the primary tumor really seems like the last thing that we do, right? So that after we've given so many biologic tests of time.
Non-obstructive. That was, I think nobody mentioned that, and my fault too, but the key thing on your very first slide is that this patient had no obstructive symptoms. That clearly changes the management priorities in a very substantial way. So I just want to make sure we're noting that.
All right. I think we are out of time, so thank you to the panel for all of your wise words, and thank you to the audience.
Okay, I think we're due for a break. So it's 10:10 now, so the break is till 10:30.